Thank you, dear Chairman. Good afternoon, dear colleagues. I have no disclosures. So I will talk about carinal resection, that is defined as a resection of tracheobronchial bifurcation with or without lung parenchyma resection. It's a rare occurrence condition. The workup is usual, considering the oncological workup and the functional workup, but what we should emphasize is that local extension evaluation of the disease is critical. First, with flexible bronchoscopy, it's crucial to evaluate the length of the tracheal wall and bronchial bifurcation involvement. And you may use esophageal ultrasound if you're suspecting a tumor extension to the posterior mediastinum, esophagus, or anaphyseum. And if you could, steroids should be avoided before the surgery because of anastomosis problems. Considering the technique, first oxygenation during the anastomosis time. You may use the cross-field ventilation. This is the most used technique at the moment, but 5 years, 6 years ago, ECMO went into the field and may be used during the anastomosis phase of the surgery. The approach is usually a right posterolateral thoracotomy for right-sided disease, including lung resection. And for isolated carinal resection or left-sided, a sternotomy could offer a nice view of the carina here. You can see here. Always frozen section to be sure that all the margins are negative before starting the anastomosis. And at the end, buttress with the thymus tissue or pericardial fat pad flap to protect the sutures. Recently, 5 years ago, I told you, ECMO arose from in this field. Only case reports or a series of less than 10 patients, mostly VV ECMO. There is no additional value of a VA ECMO in terms of exposure, surgical exposure, or usually you don't have hemodynamic problems during this kind of surgery. It's an oxygenation consideration during the anastomosis time. You may use more than 75% of cardiac output flow. There is no major bleeding, and it has been proven to be safe and feasible. And you're avoiding intermittent apnea, intermittent sutures during this phase. The other recent improvement, only case reports too from high-skilled robotic centers using for oxygenation ECMO, cross-field or spontaneous ventilation. It's like feasible, but it's only few cases, and it may facilitate the post-op rehab. At Maryland, we did 39 cases over the past 15 years with a mean age of 54 and majority of male for squamous cell carcinoma and adenoid cystic carcinoma and other type of cancers. It's between 3 to 10 cases a year. We mainly did sleeve right pneumonectomy, followed by only carinal resection, and also sleeve right upper lobectomy extended to the carina, and a few left resection. Mostly were approached through a right thoracotomy and median sternotomy. We used ECMO. We have been using ECMO since 2020, so it's 8 ECMO in this area. This is the first example of right upper lobectomy extended to the carina with carinal reconstruction with the azygos vein divided. We are using a reconstruction with an anastomosis between the trachea and the left main bronchus and the reimplantation of the truncus intermedius in the right lateral tracheal wall. So first, you see that right thoracotomy offer a good view on the carina, left main bronchus and right main bronchus. This is the carina with the tumor at the origin of the bifurcation. We're starting the suture between the left main bronchus and the trachea, usual tracheal suture. We're using Rennes suture on the more distal part of the anastomosis from the surgeon, and complete the anterior part with interrupted suture. Once it's done, we are making a window on the lateral part of the trachea, keeping in mind that you should keep some cartilage at the level of the membranous part to let open the hole before the anastomosis. This is a view through a sternotomy, carinal tumor, you see on the CT scan. You're dissecting the carina between the ascending aorta and the superior vena cava, and you have a good exposure of the carina. Once again, it's the same reconstruction, but we are not removing some lungs, getting the left main bronchus, the right main bronchus, and then the trachea. Frozen section to be sure that all the margins are negative. And we started again the suture, the trachea to the left main, opening the right lateral side of the trachea, keeping some cartilage on the side of the membranous. And anastomosis. In this case, it was cross-field ventilation. We pushed the double lumen tube on the left side and then make the anastomosis. This is the flap at the end to protect the suture from the vessels. The last case I wanted to show you is a right-sided carinal right sleeve pneumonectomy extended to the superior vena cava reconstruction. You see the view of the carina, posterior view. We started by the vessel reconstruction, interposing a PTFE graft between the resected vein, using running sutures of proline, then protecting the graft and opening the airway to remove the lung and reconstruct the airway with hand-to-hand anastomosis between the trachea and the left main bronchus. In this operation, we used the cross-feed ventilation, and you'll see that we are using a sterile tube, usual endotracheal tube, sterile, inside the left main bronchus, here. And then it's a simple hand-to-hand anastomosis between the trachea and the left main bronchus. Regarding the survival, the overall survival is 60% at 5 years and 54% at 10. The operative mortality is low at 5%. Morbidity mainly due to pneumonia, no much bleeding, and 6 partial dehiscence of the anastomosis treated medically with surveillance and antibiotics. According to the histology, for lung cancer is 39% at 5 years, and it's better for the adenoid cystic carcinoma. As conclusion, carinal resection became a standardized technique. The use of ECMO facilitated the anastomotic phase without an associated increase in bleeding risk. Carinal resection is a safe procedure in experienced centers and can be associated with good long-term survival. And the robotic approach may be a promising avenue to develop and further investigate, maybe allowing these patients to benefit from minimal invasive surgery. Thank you.
Comments?
Van Amnon, Leuven, Belgium. Olaf, very nice presentation, great series, and good results, well presented. In your last video where you did the right sleeve pneumonectomy with reanastomosis of the left main bronchus onto the trachea, I presume you have to do some hilar release to get the two ends together. So how do you do that from a right thoracotomy?
So you mean from the left, yes, the last video, right?
The last video, yeah.
Yes. There is not so much trachea and main bronchus removed. So we can, for the left release, we are just dissecting the anterior part of the left main bronchus down to just behind the aortic arch, and as far as possible, and you can have a sufficient mobilization of the left main bronchus. And on the tracheal side, we are dissecting the anterior part as a mediastinoscopy of the trachea, as far as we can do with the finger. So we have a mobilization of the proximal part of the trachea and distal part of the left bronchus.
Can you divide the left pulmonary ligament from the right side?
No, not at all. Yeah. But yes, in this case, it was it was the origin of the right main bronchus, and yes, if it's left-sided, we are using a sternotomy, yeah, and we may divide the ligament, more dissecting things.
Once again, nice presentation.
Thank you.
Shubani from China. And so thanks for a great presentation. And I have two questions. And first of all, first question, you mentioned that ECMO would be one of the better options. However, in China, maybe in China totally there are more than 300 of the cases of carinal reconstruction, but most of them would not need ECMO because we should mention that ECMO also has some disadvantage. The one is the high cost, and secondly is one of the damage to the system of the bleeding. So in China, but however, for the traditional intubation, they also have some disadvantage because patients should receive the cost-free intubation. And we also, up to your video, we can see that. The second case you mentioned that it's an end-to-side anastomosis. However, you also mentioned that for the because the cost-free intubation, you should be careful. But however, in China now, we just use non-intubated. Let's keep the patient to keep spontaneous breathing, and we can complete the end-to-side anastomosis and avoid the cost-free intubation and avoid the stop the anastomosis. Just now.
Yes, you're right. It's very interesting. We don't have the experience, but it may be something that we should study and evaluate. Yes, absolutely.
Yeah, thank you.
I mean, I have been using ECMO. It's very convenient. So in your center, are you continuously using ECMO?
Yes, because we are also a transplant center, so ECMO is not really a problem for us. The chest is open. We have a direct access to the right atrium. So we are just putting 2 cannulas for half an hour inside to do the anastomosis and then stop with really low anticoagulation. So, but I could understand that if you have no access to this kind of technology or you're not used to using ECMO, the other technique may be very interesting. Yeah.
Especially for the pediatric age, I think ECMO is the way to go.
Sure.
Your institution has a very long history of resection of the T4 tumors, and you presented nicely that it can be done with low morbidity and mortality. But neoadjuvant chemoimmunotherapy was out, and most of the patients with lung cancer are candidate for neoadjuvant chemoimmunotherapy. What is your latest, the latest strategy for these patients, especially not for the tracheal tumors, of course, but for the pulmonary tumors with carinal resection? Would you continue to perform carinal surgeries without any neoadjuvant therapy, or
No, we are doing the chemo-IO induction therapy in the modern oncological management of patients. So it's less patient than before, but we are continuing doing such cases after chemo and immunotherapy. Pancoast, Carinal, all T4, we are doing chemo-IO induction and then the surgery if they deem operable on the pre-op workup.
I have one question about the vena cava superior reconstruction. In the patients with vena cava superior invasion, we had some experience that after reconstruction of the vena cava invasion, after reconstruction, the current in the after the reconstruction, the flow in the system unfortunately is suboptimal, and it can cause obstruction because of the collateral flow in these patients. What is your strategy in these patients? Do you routinely perform angiography after operation in order to check the patency of the graft?
It's an excellent question. We look at the collaterals on the CT scan. We are doing less angiography, but before we did angiography. What is really important is to close every collaterals you have access to before doing the bypass. So that's why you saw that we systematically divide the azygos vein and all the vein you remove the tumor, and with this you have a really less risk of bypass occlusion or difficulties. But if you're letting some collaterals in place, it is a problem, yeah. And maybe if there is a lot of collaterals and the SVC is totally occluded, maybe you should not replace it.
Very quick.
Yes. 11 of your 39 patients had adenoid cystic carcinoma.
It's not 39 adenoid cystic carcinoma.
No, 11 of 13.
Yes, 11, yes.
11 out of the 13. And a lot of these patients have perineural invasion, and a significant percentage of them need postoperative radiation.
Yes.
In an era where interventional pulmonary or thoracic surgeons are able to debulk the vast majority of the endobronchial component of the tumor, where there's only very little on the stalk, if there's a high percentage that these patients require postoperative radiation, what is your thought about doing a resection in these patients? I know the resection is done very elegantly and safely, but how adamant are you to recommend a resection, especially in an older patient, if they're going to need radiation in a significant percentage of the time?
So radiation is very powerful in case of minimal disease and even microscopic disease, R1 disease. But when you have a macroscopic tumor, it's less effective than the surgical resection. So, and usually the part of the ACC inside the trachea is not maybe the same side outside the trachea.
Like an iceberg.
Yeah, so that's why I would recommend more in my practice to remove the tumor if you can, because you have less morbidity and your patient is fit enough to have the surgery. I would recommend to do, yes, maybe a R1 surgery, because a small resection, R1 microscopic surgery plus radiation, rather than to let macroscopic tumor inside the patient.
Thank you.
You're welcome.
Great. Thank you very much.
Welcome. Thank you.
Thank you, everyone, for coming.